May I take the opportunity to introduce Professor Paolo Ghia, who many in the room will already know, but just to remind everybody, Professor Ghia is Professor of Medical Oncology at the University Vita-Salute in San Raffaele, Italy. Maybe I've been trying to translate Vita-Salute because Life and Health. Thank you. He's also the director of the CLL Strategic Research Program, and of course, he's president of ERIC, who in our sessions in advocacy recently, we've been focusing on the work of ERIC with his colleague Costa. So you've got a tough act to follow, covering optimum therapy. Are we achieving it? What are we not? What do we know? What do we don't know? And provide a European perspective. Good luck.
Thank you very much. We don't know much. In particular, the time, I would say that I will be very quick. And of course, we already learned everything we don't know, and I have to say that even internationally, we are not in a better position, so we don't know much more than what you heard from both colleagues so far. So what we try to do is, anyhow, I want to give you an introduction of the ERIC, the European Research Initiative on CLL. UK is still part of it, though it is a European association, but we still keep them. We are good. In particular, because the ERIC is trying to expand internationally, so the name is European, but the aim is really global. And you will see it in a couple of slides. It's a non-profit organization that legally is resident in Germany, and was established now more than 10 years ago, almost 15 years ago. And our working office is in Barcelona, actually. We are also the scientific working group for CLL within the European Hematology Association. And we are also the partner for CLL within the Leukemia Net. So in Europe, wherever you talk about CLL, ERIC is involved, in particular for the simple reason that everyone who is working for CLL is somehow connected or a member of the ERIC, because we try really to be very comprehensive. And this is indeed the membership. In the last few years, we really tripled the number of our members. And the members are distributed in 79 countries, so you understand that it's not only Europe. And here you can see the map. It really spans all over the world, and we are also quite well represented in Africa, definitely in South America and Asia, Europe and Australia. So what is our mission? The mission is very broad, but also very specific. We want to improve the outcome of the patient through research. That's our aim, and the research can be basic, translational, or clinical, though most of the work, as you heard also this morning, or yesterday also, from Costas and our distinguished colleagues, we really aim at translating the basic findings in CLL into the clinical arena. So we really put a lot of effort in improving and bringing access to a lot of tests, genetic tests that can be helpful for the diagnosis and the prognosis of our patients. This, of course, our belief is that we can only obtain results if we collaborate, and that's the idea of being so many involved within ERIC. Not only at European level here, we should say at international level. Just one very recent piece of news. A very recent piece of news is that really in the past few weeks we added a section in our website, which means that about patients. So there is a section dedicated for patients. Don't go there at the moment, there is not much. But as you heard from Aliki yesterday, I think we are working on an empowerment, a patient empowerment program together with you, together with some of your representatives. And that's really something in which we believe, because of course all the benefit hopefully of our research will be for the patients, but also because without the help of the patient, in many instances we cannot really make the authorities, for example, to understand the value of the research that we are carrying on. So I just want to take the opportunity here to show you, this is the first time that is shown in public, I have to say. So these are the updated EHA ESMO guidelines. So this is also the first time that the ESMO guidelines are indeed done together with the EHA, the European Hematology Association. And those have been submitted before the summer now. And as I said, I'm going to show it tomorrow. On Sunday here at IWCLL, but this is the first time that someone is seeing them, and these are the treatment guidelines for patients in first line, treatment naive patients. And as you can see here, probably you will see that they reflect exactly what you heard also from Anna Shu a little bit earlier. We have to stratify the patient based on P53 mutations and deletion, the P53 aberrations in general, and that's something known since a long time. These patients should not be treated with immunochemotherapy, but only with novel therapies when they need treatment. But then the important message is that patients should be stratified based on the mutational status of immunoglobulin. You already heard by Kostas Stamatopoulos a lot about it, and this is indeed now in the guidelines. And as you can see, patients with unmutated immunoglobulin genes, they should benefit first from novel therapies. So the best option would be novel therapies, where these are, of course, accessible and are reimbursed. For the mutated patient, then, as you heard also from Anna Shu, both immunochemotherapy or ibrutinib, or maybe venetoclax plus obinutuzumab for those countries where it will be reimbursed, hopefully soon, are similar options. There is also an update for the guidance in the relapsed refractory setting, and this is much blunt, I would say, black and white, meaning that, of course, for patients with P53 dysfunction, still they can benefit only from the novel therapies, but also for the patient who relapse after chemotherapy and they do not carry P53 dysfunction, still in second line, novel therapies are the best option for the vast majority of them, those who had a short remission duration, but also, and this is the big piece of news, also for those who had a long remission duration. Of course, you can still repeat the frontline. Here we are very clear, better not to repeat FCR. In the old guidelines, some doctors still thought that it was something feasible. This is not, if you did 6 cycles with FCR, it's virtually impossible. You can tolerate another 6 cycles. So in general, even for those who have longer remission duration, the novel therapies are considered to be of benefit. So more or less in the second line and in the relapse setting, there is really a very narrow space for immunochemotherapy. But anyhow, the issue, as Anna already mentioned earlier, the issue is really that we don't have these drugs available everywhere. And if the situation in the UK is terrible, in Italy it's not a lot better, meaning that, for example, ibrutinib is reimbursed only for the patient above 65 years of age. So below 65 years of age, you can just discuss with the patient if they have mutated and unmutated immunoglobulin genes, and at the end you say, sorry, but I have to use immunochemotherapy anyhow. And so as also Anna suggested in our practice, but we are lucky, we usually suggest the patient to enroll in clinical trials where they have opportunities to be treated with novel therapies. And of course, why this is so relevant, you already saw this curve by Anna Shu. This is a curve of the ECOG study where patients, first line fit patient, have been treated with either ibrutinib plus rituximab or the traditional FCR. And as you can see, and as you already seen, patients treated with ibrutinib-based treatment do better. But in particular, those who will benefit the most are the unmutated patients. For the mutated patients, still they can have both benefit from immunochemotherapy, FCR or ibrutinib, but still also these patients can benefit from the novel therapies for the simple reason that, as you saw, there is an advantage in overall survival with the novel therapies, and in particular also in the long run, it seems that they might have less adverse event than immunochemotherapy. The same thing holds true for elderly patients, fit patients, in comparison, as you saw before, with bendamustine in black, compared to ibrutinib alone or ibrutinib plus rituximab. Again, on the right side, unmutated patients treated with ibrutinib-based treatment. The two top curves are those who really benefit the most compared to those who have been treated with bendamustine plus rituximab. And also, in the mutated setting, with bendamustine, though at the moment there is no statistically significant difference between patients treated with bendamustine, the lower curve, or ibrutinib-based treatment, the top two curves, still the two curves are really diverging. Maybe with a longer follow-up, we will see that indeed bendamustine plus rituximab is not so effective in mutated patients. And that is something we already know from the CLL-10 study. So they never reach a plateau, so they never give that possibility of cure that you can reach with FCR. And again, last but not least, ibrutinib-based treatment. Here I show you obinutuzumab. The same thing will be true for ibrutinib alone. A patient with, on the right side, patient with poor prognostic factors, like also unmutated immunoglobulin gene, they benefit very nicely with the use of ibrutinib plus obinutuzumab in this case, compared to chlorambucil plus obinutuzumab, which is the best, which was the best treatment for patient elderly and fit. So, but just to remember, the patient with mutated immunoglobulin genes still, they might, though they might still benefit from immunochemotherapy, different immunochemotherapy depending on the age, still the mutated patients are very few. Patients with mutated immunoglobulin genes are the majority, as you see on the left side, of all patients with CLL. But when you move to the patient who need treatment, then the opposite becomes true. So the vast majority have unmutated immunoglobulin genes, so in blue. And if you consider those who need a treatment and can tolerate, for example, FCR and have mutated immunoglobulin genes, those are only 30% of all patients with mutated immunoglobulin genes. So at the end, 1 out of 10 of the patients who need the treatment will have a mutated immunoglobulin gene. So the advantage that we can have for those patients who can be still treated with immunochemotherapy is very limited. The vast majority, when we don't have access to novel drugs, like in the UK or in Italy for the young patient, then we are really making something bad. So that's why the ERIC is really advocating for testing the immunoglobulin gene in all patients since many, many years, and created an immunoglobulin gene network that is explaining, educating the community about the relevance of testing all patients for immunoglobulin genes. And in particular also we created a certification system to certify the labs all over the world to have a reliable analysis of immunoglobulin genes, because the worst that can happen is that you are tested but then the result is not reliable, and that can still happen. Especially because when the procedure is not done properly, then the typical results would be a mutated result, which is of course bad, because the patient, in case he is unmutated, he would receive immunochemotherapy. As you can see, there are many centers all around Europe, but also around the world, in Argentina, Australia, Taiwan, and USA, because we hope that every patient can get the same access to the proper analysis. Of course, also P53 is relevant. You already heard from Anna Shu, and again we have the same similar network with again advocating for the importance of testing the patient and for certifying the laboratories who are testing the patient. So just I follow the path that you heard already from the previous speakers. Remember, so no molecular testing at diagnosis, but only before starting the treatment. A diagnosis is not needed. You cannot predict really how your disease will be based on the genetic markers, because there are always exceptions, which are 10–20% of cases, which means that quite abundant as exceptions. Remember also, don't do any bone marrow aspirate or biopsy at diagnosis. This is not like all other leukemias. Too many times bone marrow biopsies are done, which are not necessary to do anything, a diagnosis. You don't need anything of that, exactly as you don't need to be followed by CT scan. Okay? Here we are talking a disease which is indolent. We don't really care knowing about millimeters of our lymph nodes. We need to know only when the lymph nodes are very large. And so the message that also Eric is trying together with the Patients Association to deliver, it is really to underscore the importance to test before starting the treatment. And you may say, why should we do that if we don't have access to the drug? Because like we are doing in Israel, and that happened in 2 years, we went several times to Israel holding seminars explaining the reason of molecular testing. The doctor started doing it. In Israel, there are probably 2 or 3 laboratories that are certified by Eric, and now they are discussing with the politician that they might have access to ibrutinib in first line for unmutated patients. And that is really a reality that happened in 2 years of work. The last point that I want to make, because it's something that we usually forget, is that we should always, we as a doctor, I always say to my collaborators, always write in your records why you are treating the patient. Not because he has leukemia. Who cares? He has that since 10 years. Why are you now deciding to start treatment? And what I always say to my patients, especially those who come in second, third, fifth, 10th opinion, I say, go wherever you want, but always ask one question. When the doctor tells you you need the therapy, you have to ask him always why, okay? And why? Because there are criteria which are very precise, so it's not that I'm getting scared because it's a lady. I definitely agree with my colleague. My youngest patient, 19 years old, was a girl. Everybody was stressed, of course. It's a girl, 19, CLL, we need to start treatment. Why? I mean, it's not her fault to be young and girl. I mean, don't be so bad. So we have really to follow the rules. Progressive marrow failure. So if you are anemic below 10, if you are thrombocytopenic below 100,000, it's not true anymore. It's a level that we say to the patient because it's easy to remember, but you can go lower than that. We learned that from many other diseases. So usually, for example, in my practice, we start treating when we are around 50,000. So definitely much lower because there is no risk. Patients with CLL are not bleeding, are not acute leukemia patients, luckily. Massive nodes, bulky lymph nodes, which is a very general term, especially in the lymphoma environment. That means 5 centimeters, and that is used also in CLL, which is not true. I mean, since 2008 in the guideline, it's written 10 centimeters, which is much more. It gives you like at least a couple of years of time without being treated, which is always good. Also because, as I always say, the best treatment has yet to come. So in 2 years' time, maybe we have something else. So it's always better to wait. So 10 centimeters, remember the magic number. 10 centimeters, 10 grams of hemoglobin, 100,000 platelets. It's easy to remember, but too many times patient comes in because the doctor said, well, you are already 5, 6, 7, you will become 10, so let's start now. What's the reason? There is no real reason. And in particular, I want to remind you the story of the progressive lymphocytosis, the increase of lymphocytes. Of course, it suggests that the disease is moving, so it's not stable. Unfortunately, you will need therapy, the patient will need therapy. But again, there are many reasons for which the lymphocyte can increase, so it should not be the only reason to start treating a patient, and we already underscored that together with Michael Halleck. So if that is the only criteria to start the treatment, maybe it's better to go back to square zero and to redo your diagnostics, see if there is any other reason why the patient must have had that, or confirm that a second time to see if it is really a sustained attitude of the lymphocytes. Exactly like constitutional symptoms. Too many times patients complain because the patient sometimes wants to attract attention of the doctor. The doctor is also scared by the patient who is concerned because maybe he's afraid that he wants to attract the attention of a lawyer. So that's the vicious circle that happens too many times. So the doctor starts treating, and when they talk to you as a doctor, they tell you, but the patient wanted to be treated. And then when you talk to the patient, you says, but the doctor wanted to treat me. And then you never understand why you started treating, okay? Because everybody was scared. Scared because the patient started saying, I'm feeling tired. We are all feeling tired. Today I woke up at 4 o'clock to take my airplane, so maybe I'm tired, but how can you understand if that is due to the disease? If you are losing weight, 10%, better to do a colonoscopy, better to think about colon cancer. I never saw any CLL patient who just suddenly loses weight and nothing else happens. And so like fevers or night sweats, probably it's not a problem in the UK. I can tell you that in Italy, in particular, some months you sweat a lot at night. And that can happen. So besides jokes, it is true that one should really evaluate the patient globally to really see a sick patient, okay? It's not a patient who is complaining about one symptom that makes the patient ready to start the treatment. So this is something that also patients should be educated not to overreact to their symptoms. Maybe I see too many patients coming to me who are dead, walking in my office saying, I'm dead, my leukemia is killing me, my doctor wants to start treatment, and then I check at the charts, at the tests, at the exams, and I say, but I don't see anything really relevant, but I'm feeling tired. I said, yeah, but how do you sleep at night? Are you worried about your leukemia? Maybe you wake up in the middle of the night, maybe your wife is snoring and you don't sleep, whatever. So there is always a reason. Maybe there are psychological problems, so the patient is not sleeping. So that's another story, so he feels tired, and then everything becomes difficult. So the worst is always to start the treatment and the patient doesn't get any benefit, because if he's tired not for the CLL, he will not recover from that. So I want to conclude here. Maybe we keep it for the discussion. The issues of the future, as I said, we don't cure probably anyone, maybe some few lucky, but we have a number of issues. The first thing is toxicity of the drugs. Even the new drugs are not candies, can have toxicity. We are again maybe overreacting to these toxicities, both the doctors and the patients who don't remember maybe anymore the toxicity of the chemotherapy. So there are too many patients who discontinue these wonderful therapies without really great reasons. And they are immediately defined like resistant intolerant to these drugs. And then after those, we don't have much else. Relapse, the problem of relapse, so now we are getting to another genetic problem, another testing problem. Patients should be or should not be tested for the novel mutation. Here I said BTK mutation, but also the BCL2 mutation for the venetoclax. This is an issue on which we are discussing a lot and we will discuss in the future. The other thing is the continuous treatment. Nobody wants to be treated continuously forever. It costs too much. We expose the patient to too many adverse events. We have to find a solution to have limited treatment, and we have the possibility now with the combination of the drugs. Thank you very much, and we can discuss that later.
I'm conscious we don't have microphones at the table. I thank you very much, all the speakers. That was excellent. So any questions? Yes.
Hi, I'm a patient advocate. I'm a patient advocate, and I actually moderate a website where patients across the globe are sharing their experiences and treatments. In the UK, patients are increasingly concerned that unmutated patients are still receiving chemotherapy. My question is the FLARE study looking at mutation status as a discriminating factor in terms of perhaps recommending future treatments? Does that make sense?
Yeah, the FLARE study is looking at that. Obviously, we have to wait for the FLARE study to be analysed and report. You're asking a very important question, and it's essentially also about, who should go into flare at the moment. Now, the problem, of course, we have is that because we don't have any other option for those patients, this is still ethically the best option we can offer at this point. I have to say, though, and I don't normally, offer private treatment to my NHS patients, but now, because of the results that we have all seen and were presented this afternoon, if people have got private insurance, and I would never have thought, because I'm totally convinced by the NHS, and by public health systems, but if ibrutinib is available privately, then I would advise to have ibrutinib privately, because I go on the evidence that is in front of my nose. For all other patients, I think the FLAIR study is a very good option.
Hi, Dr. Brian Kaufman, the CLL Society, US-based. So let me ask you a first world problem that I'm seeing. I'm a big believer in test before treat, but I'm getting pushback from some docs saying, but I'm going to put everybody on ibrutinib, and it works for everyone. So why do I care what their mutation status is, what their FISH is, because I'm just going to put them on ibrutinib frontline?
That's definitely a good question. I mean, among the many mistakes that are made in CLL, we can probably forgive this one. It is true that you can save some money, probably not an issue in the US. So for many reasons, you can avoid doing it if you really don't have a reliable lab, if you don't have, if you have money constraint and so on. But the issue is that at the moment, we don't have such a long follow-up that we can really say that ibrutinib or venetoclax or whatever, they are working exactly the same in all type of patients. We already saw, for example, venetoclax. We saw the results of the CLL 14 study, venetoclax plus obinutuzumab compared to chlorambucil plus obinutuzumab. In patients with p53 abnormalities, still benefiting from venetoclax are relapsing earlier than those who do not carry p53 aberration. So I think that it's anyhow relevant, because at least when the patients stop responding to any drug, at least you already know what background, what genetic background has that patient, particular patient, and you can take your decisions. Because of course, if a patient has a p53 aberration, for example, he's relapsing after ibrutinib, maybe it's a patient where you would like to try CAR T-cells now before going to venetoclax, which is the last option, really. So I think that the more we know, it's better than to be in the unknown. So it doesn't cost so much at the end.
Yes, there is right at the end.
I wanted to ask, a lot of the ibrutinib and venetoclax is available on FLAIR, but I understand FLAIR will be closing in June, so how will we be able to access these drugs after June next year?
So that's also a good question. Hopefully they will be, so we are going to talk a little bit about this later on in the second session, about the upcoming trials and the trials that we've planned. There will be a gap, that's for sure. There are, however, some commercial studies that will and are currently opening in the UK and will be open by then, including a study of acalabrutinib, both for treatment-naive patients and also patients with relapsed CLL. And this is a 3B single-arm study, so everybody will be able to access acalabrutinib, and that's a sort of son of ibrutinib, if you like. So we think that will provide a stopgap. It's difficult to say for how long that study will recruit, maybe for a couple of years, and hopefully by then there will be another study up and running. There is also, we are banking on having venetoclax and obinutuzumab available. That is with NICE at the moment as part of a technology appraisal process. And I believe that Janssen, if anybody from Janssen is in the audience, I might have seen one or two people, I'm not looking into their direction. But if, there's a study, the GLOW study of ibrutinib and obinutuzumab that will report, and it might well be that study goes to NICE. Because the problem we have, to be fair to the government, the UK government, is not just that NICE doesn't approve ibrutinib, it's also that Janssen doesn't bring ibrutinib to NICE. We are kind of caught in the middle of two very potent organizations.
There was a question. Yes. Hi, Jan Wren from CLL Ireland. I have a question probably for Professor Fagan. You mentioned infection. As a CLL patient, infection seems to just be part of the journey, whether it's initially at diagnosis or during treatment and even beyond. And I suppose you touched a little bit on damaged immune systems, but I suppose my question is, is the treatment purely prophylactic antibiotics and immunoglobulin replacement therapy? Is there any kind of research happening into replacing our IgAs and our IgMs as well as our IgGs? Is there any of these novel treatments that are showing potentially some sort of repair in the immune system, or is it something we're just going to have to live with and suck up? Sorry if it was a long question.
The answer to all those, I'm afraid, is there's very little going on. I'm afraid a lot of research is driven by big pharma, trying to answer big questions. There's not a lot of money in this antibiotic is better than that antibiotic. This vaccine is better than that vaccine. There's not a lot new going on is the truth of the matter. The things which I think are important is, of course, a lot of GPs, they're under great pressure not to prescribe antibiotics to people. You have to resist that, as Anna showed, 14 days minimum. I use 10 to 14 days for routine infections, not the 5 days or 7 days. You need a longer duration. That's an argument you have to have with your GP. I recommend you have prophylactic antibiotics at home, but where's the evidence base of all that is actually very weak. And I think it is an area where the patient group, they're relatively cheap studies, where the patient group can put their pressure on the funding organisations to make sure these sort of studies happen. Back to vaccination, there's various attempts have been made over the years to make vaccines more effective. We haven't really had any of those studies in CLL. It doesn't mean we're going to find a way of doing it better, but we haven't really got very far in trying, is the truth of the matter. And that's become more important. In the past, we didn't have very, very effective therapies. Before fludarabine came along, it wasn't the most burning issue. The most burning issue, let's get some effective therapies. What you're talking about is survivorship, and that's actually going to be what most people in this room are concerned about. We have lots of excellent tools in the box. We never had them before. How best to use them, we're still trying to work our way through. But that's not going to take away the infection problem. That's going to be with people long term, and I think we will eventually get round to that. But with pressure groups like yourselves, maybe we can bring that question forward earlier.
And I had a comment and then a question. The comment follows on very nicely from the earlier question, which I completely agree, but I think it's even more than that. To add to your known unknowns, we know nothing about how to advance. I sort of said I'm a patient with CLL, and we know nothing about what we as patients can do in terms of our lifestyle, what we eat, how we exercise, what we do, in terms of particularly reducing our risk of getting those infections and then actually living well with our disease. And then I wanted to pick you up. I agree with you completely on your slide when you said we need to know the order in which to give treatments. And my question really is, how do we do that? I had FCR as my first-line treatment. I'm currently in the Clarity trial. One of the dilemmas for me in making that decision to go into the trial was I'm putting all my eggs in one basket. I've had ibrutinib plus venetoclax for my relapse. What I hesitated about was, should I just go with the ibrutinib, which was on the NHS, and save the venetoclax for later when I have my second relapse? And now FLAIR includes, based on preliminary Clarity results, FLAIR includes ibrutinib plus venetoclax for first-line treatment. What are you going to offer those patients for their relapses? Because that's part of the discussion. And it's not just looking at we're all interested in much longer than the next, all these slides are a few months. I've said enough, but I'm really interested to know how we can we can do some of those trials that answer those really important questions for patients?
There's several points really. We're making the assumption all the BTK inhibitors will be the same. That may not be correct at the end of the day, but we'll have to wait and see whether that is so or not. Chemoimmunotherapy, in the history of chemotherapy, is you get more bang for your buck if you use your most effective treatment up front. Virtually all cancers have shown that. So if, for example, ibrutinib and venetoclax is the most effective combination available, then history tells us that is what you should have up front, if. And it's a very big if I can say. But in theory, chemoimmunotherapy, the resistance mechanism shouldn't be across the two different therapies. So it doesn't mean that you may not respond to FCR if you've failed IV. The good news is there are new drugs on the horizons, bispecific antibodies, new monoclonal antibodies that come along. I think CAR-T will be perfected. The amount of money being spent on CAR-T, it will become a lot more effective for more patients than maybe at the moment it seems to be the case. So you are in a bit of a dilemma. Am I putting all my eggs in one basket? I think the honest answer is you probably made the best decision, but that doesn't mean you're not going to have sleepless nights about what happens if. But there are new things coming, and those combinations, we haven't quite worked out those combinations yet of the various agents. For example, VI is very, very potent, but maybe VO will give you some sort of response until the next really new thing comes along. What's your thoughts, Paolo?
No, that's absolutely the key question that we are all asking. I'm happy to hear from you. And sometimes, I mean, you should ask that question to many investigators, because sometimes many investigators lose that perspective. The idea is to publish a paper and not to really probably cure the patient at the end of the day, meaning that, as you said before, the patient should be informed that the disease is a journey. It's not one single trip. And I always say, probably also in the UK it would work, I always talk about soccer championship. So it's not the final. So every treatment is not the final of the championship, but it's really the whole one Sunday after another Sunday, which means that we have to win at the end and not really the first game or the second game. So what I always talk to my patient is about the planning, exactly what you said, what if? And you have to think about the what if. Having said that, of course, the combination of venetoclax plus ibrutinib is very attractive, and the concern is indeed what I'm going to do after that. But it's also true that there is the advantage of a limited treatment. So at the end, if you relapse, it is very likely, we don't know, but it's very likely that the patient will still respond to either of the two drugs. Or maybe, as he mentioned, we will have new BTK inhibitors that are working against the mutated BTK, so maybe we can switch ibrutinib with that new drug, and so on. So that's the idea of combining everything at the beginning to get really a deep response, maybe a cure in few patients. If the patient relapses, then maybe we can restart again with each single drug or combination with antibodies, and so on. But of course, we are in the process of discovering it. But the idea I really like is the idea of thinking about the future, meaning that not only today, am I going to respond today or not? Who cares? 1 month or 5 months or 6, we are talking, we want years or decades. So that's a real question that everybody, every doctor and every patient should ask before starting any line of treatment.
Hello, this is a question for the panel. My name is Ciara O'Donovan, I'm with CLL Ireland. Firstly, an observation, really a great opportunity to have patient advocates and clinicians in the same room and such things, so that's to be really welcomed and to be applauded. And I think it's a move, it's a really good move in the right direction. And the fact that it's been recognised in ERIC for patient advocate involvement as well moving forward is to be applauded. My question is about future of clinical trial development and involving patients in the design of clinical trials moving forward, which is something that all is advised that it should be moving forward, and what's the status in that for CLL trials?
Yeah, so I can maybe start off with answering the question. So in terms of the patient involvement, I'm a total believer in this, and I think that was, you know, the fact that this meeting has happened is essentially a result of the collaboration we have, you know, very closely with patients, reps like Nick, Gary, lots of other people here in the audience, David, and they sit on our committees. They sit on the NCRI subgroup, which is the committee that decides about the new clinical trials. They've also been very helpful in providing input into the Genomics England program, which is the big kind of sequencing initiative that we've initiated in CLL. Obviously, we have the CLL forum that Renata now chairs, but there are patients sitting on the executive committee there. We are really trying to get as much feedback and active patient involvement from the patient representatives. I still think that it's not enough. I think a lot more can be done with respect to education. I think there's also, it's quite challenging because a lot of CLL patients are a bit older. They go through periods of time where they're a bit frail, where they undergo treatment. So there's a fluctuation in people and how often they can attend and so forth and so forth. So it's a challenging subject. But the NIHR, which is our kind of national research organization, has now come up with a charter for patient engagement and involvement, and it includes every stage of research, from the design, from the initial questions, all the way through to the more classical things like reading through the patient information sheet, making sure that everybody can understand it, to the analysis, to the report, to the dissemination of the results. All of this needs to be led, and patients have to be very actively involved in this, and I'm 150% believer in that. Now, how we can make this a reality is a much more complex question. The Oxplode study, which is the study that I've just started and is open now in Oxford, that looks at pre-malignancy, both in patients with pre-malignant multiple myeloma and CLL. We are recruiting probands, almost 2,000 across the UK. That came out of the Watch and Worry campaign. It was essentially the idea, the patients were saying that we're being watched and worried, we don't know what's wrong, we know 95% of us will never need treatment, can we please be reassured? So this study is a result, is a direct result of trying to find biomarkers to reassure 95% of people with pre-malignancy. That was a patient question. But to make that a reality is quite complicated, because now I have patients saying, but I don't want a bone marrow, and I don't want blood tests, and I don't want to come up to clinic, and I don't want so it is actually, it's making this a reality. It can be quite challenging.
If I could just make one comment. I may be a government employee, but I do not work for the government, certainly not this crappy one. I work for patients. And we do need your input, and that's become more important as the questions have got more difficult, to be honest.
I just want to add something. Maybe what the patient can do is really to believe in what she said. Clinical trials are key. The problem is that, especially now that we have two very effective therapies, I heard already some patients that prefer to go for the standard, which is depending on the line, a protein, venetoclax, rather than to enter a clinical trial. So what patient has to perceive is that we are not at the end of the game. We don't know how to cure this disease. It's only postponing a problem. So the best therapy is the one that has yet to come, as I said before, and we have to believe. We believe as a physician. Also, the patient should start believing it, because too many patients come, for example, to me or to other colleagues who have clinical trials only when they already relapse a couple of times and they feel desperate. It's not a matter of desperation. I mean, you can do it in first line, be enrolled in clinical trials, and have the best benefit you can get. So this is probably a campaign that we all should agree, because too often there is still the belief that the clinical trial is worth only for the companies. Definitely it's worth for them. For the doctors, definitely worth for their careers. But at the end of the day, it's really worth the patient, because if the drug is working, at the end the paper is forgotten after a couple of years, but the drug will remain.
Maybe just one more question, because we're running really late.
Just changing sort of a different frame of the question. I'm Catherine from the Leukemia Foundation in Australia. I think independently of where someone's CLL is at, whether they be actively monitored and as we've spoken about, worrying about, is that cough something that's leading to a progression of my disease? And as I highlighted, what trial should I go on? Am I throwing my eggs in one basket? As the trusted advisor for people when they come to you with their CLL, what role do you see yourselves as clinicians playing in ensuring that patients have that support, whether it be from you or from outside sources like like-minded organisations like the Leukemia Foundation? I guess what my question is the role that you see yourself playing now and obviously moving forward to ensure that your patients have that holistic support to enable them both sort of emotionally to live well with their diagnosis, but as well physically with things like the chronic infection management.
Well, so just a very general answer to this is, for me, I mean, it's actually all about patient empowerment. And the problems of access to treatment or of deciding which is the right treatment, etc., at the end of the day, it's a patient decision. And I think I see personally in clinic, I see my role as somebody who can try and explain the situation in a way that the patient hopefully understands, whether this is irrespective of the patient's background. And I think globally speaking, that is really the important thing about, I'm passionately thinking about global hematology at the moment. We are spearheading the field in medicine because we've got highly effective agents, we've got precision diagnostics. We are now, the next step is to make this available to a much larger number of people, and the only way we can do this, at least in democracies, is by convincing the public and the patient and by educating and raising awareness, because they are the voters. And so the voters will go and they will vote and they will influence the governments. And that's the way you can change things. So for me, increasingly, it's to do with empowerment and with working with advocacy groups, lobbying groups, the regulators, the payers, to get these drugs and also the diagnostics to the patients. It's, the people who cry the loudest in a democracy, they will be heard. And we are living in, we're not a good example of a democracy at the moment, but this is where we are, and so I really believe that is where globally hematology has to go.
I think that's an excellent point to finish on. So thank you very much, everyone. CLL Forum continues. So if you could just grab a quick coffee, because we're running really late. I need to be out on time. And the advocacy in action continues in...
Yes, again, I'd like to take this opportunity to thank our gracious speakers. As the advocate group, I would also like to thank the generosity of the UK CLL Forum for organising this to help ensure that we can come together, and the event organisers.